I will take a few questions if you have them, but I just want to follow up on, and I thank both Mayor Gallo and County Executive Hine. We talk about collaboration a lot. Collaboration is very important. Partnership is critical. We understand our role. We're stewards. These are not just jobs that we are given. We have stewardship roles. We take that very seriously, and our job is to leave the hospital and the community in a better place than when we found it. That's really our goal. This is not merely a job. The partnership and the collaboration extends to the government at the highest levels. We can't do anything without their support, and we do appreciate all they have given to us. Any questions on anything we've presented so far? What I'm going to be doing in the next couple of months is getting out to the community. There are a lot of new terms that I've introduced today. They need explanation. They are complex, and the only way to do that is to get out and talk to the folks of the community, and that you will be seeing a lot of. So, questions? Yes?
When Health Alliance was first formed and brought into the community, there was high expectations and the hope that the health delivery system, especially in the hospitals, would greatly serve the community. We're very concerned over the course of the years that Health Alliance has run the hospitals since the merger, that the poor, the elderly, the handicapped, families, children are going to be poorly served. We have seen that the management of Health Alliance, hiring a man who had a bad reputation to begin with at an outrageous salary and his staff, finding the investments in things which possibly are going bankrupt, one Woodland Pond, the disaster of the Foxhall ambulatory meeting, all of these things and the disintegration of the staff morale, the possible loss of hospital staff or even the hospitals, is a very, very serious concern to the whole community. During this whole time, you're going to ask us to give the belief that the same board of directors that have mismanaged Health Alliance for this long period of time are going to still remain and try and bring us in the transition into a whole new concept of health care. Well, that idea may be great, but certainly the history of what has taken place under the current board has been a disaster to the community. And we are asking, will the current board members, or at least the leadership, resign and allow new leadership to come in to help us with this new transition, because the community does not have the belief that the current board will do that.
I would suggest that we take most of that question offline, but what I will tell you, I am the new CEO. I've been in this position since the last week of July, and I can share with you what my vision is and what my goals are, and give you an assurance that you will get my best effort to deliver what I just promised. Yes?
The press release says you presented, the Health Alliance presented to the Department of Health an updated plan. Can we see the plan?
We presented to them probably 6 or 8 iterations of a plan. The original plan, and I will be perfectly frank with you, the original plan spoke mostly of bricks and mortar, of expansion of one of the campuses to be able to consolidate. After extensive talks for those 16 months, we all drew the conclusion that probably wasn't the best way to go. That we needed to not build it first and then figure out how to use it, but figure out how to use it and then build it accordingly. And that was really the fundamental shift.
I remember your predecessor, Mr. Lundquist, last time he spoke publicly, said you can't see the plan yet, and the community was kind of upset about that. So I was wondering if we could see the plan.
The plan is what I just outlined. There is no, the plan always was building. There is no building plan right now.
The document you submitted to the Department of Health, the full plan.
The plan as approved is talking about physician integration and alignment, population health management, and affiliation. That's the plan. So we moved away from the old, can we make it one hospital, is it Mary's Avenue or Broadway? That's the old plan. This is the new plan.
So can we read it?
We would be happy to talk to you offline to go through what the outline of what the plan is. As Dave's trying to articulate, It's not a building plan, it actually spells out the initiatives that Dave just spoke to. So I would be happy to sit down with you and show you what that plan looks
Is
like.
it a public record, what you submitted?
At the state health
Yeah.
department, it's a public record.
Yes,
Yeah, it is.
and you could feel free to
Foil.
foil that, yes.
$6.5 million, how far is that gonna take you?
I think it's gonna give us a very good start to accomplishing our goal.
When will you reach the goal, and how much will the cost be at that point?
I can't predict that at this point in time.
Either of those factors?
Neither of those factors. If you take each piece apart, the physician integration is really our ability to build, without getting into a lot of detail, is to build an organization that is a legal structure that allow physicians to operate as an economic entity without being employed by one employer. So the physicians will remain autonomous, they will be independent practicing physicians, but it will allow them to work collaboratively with us. So there's a certain cost to doing our legal due diligence, setting up the corporate papers, working with them to set up, staff and structure. So it's hard to tell you that in 2 months we'll be done or in 6 months we'll be done. It's a process. This truly is a journey. This isn't like a building that we put it up and in 6 months you can see the progress. This will take time for us to
And
develop.
what if the $6.5 million runs out before you get there?
We know that that's an adequate amount of money to get us there.
Is the plan still to close Kingston Hospital?
No, as I said before, the plan is to consolidate to a single campus, but we'll determine which campus and what that looks like after we finish these two initiatives.
So now it's changed from definitely Kingston Hospital closing to we're gonna see which one now. I mean, it was pretty definite in the past that Kingston Hospital was closing. It sounds like that's not a definite thing right now.
Our preference would have been to come to the Marys Avenue campus immediately, but the cost associated with building an emergency department here at the time makes it prohibitive to do until we can figure out what we're going to look like.
Okay, so closing Kingston Hospital has been put off.
Yes.
Because that was, yes, okay. The physician integration thing that you
Yes.
talked about, that's not a new concept, right? I mean, the hospital's been talking about this for some time. I believe the mayor, in fact, a few months ago, even suggested that the hospital look into this very thing. So this is not something new.
No, we had, about 18 months ago, we had reached out to our primary care physicians and asked them if they wanted to join a physician alignment group. At the time, they expressed interest, but they were exploring other employment opportunities. They've chosen to stay independent, so this is an opportunity for us to work with
To
them.
move forward on this, on
That's
making this thing.
Yes.
The population thing you talked about, can you explain that a little bit more? That sounds like, doctors really becoming involved in the way they're taking care of you and almost requiring you to do certain things. Is that right?
The first part of it is absolutely correct. The doctors will be much more involved, as will their office staff, in monitoring your health. Well, let me give you a very simple example. We all have electronic health records. The hospital in May just finished putting up its electronic health record. Physicians have electronic health records in their offices. You might notice when you go to a doctor, they're probably entering things into a pad or into a computer. What we'll be able to do over time is take all of that information and bring it into a usable format, so that physicians and care, what we now call care coordinators,
Yeah.
can take a look at you, for instance,
Yeah.
and know that based on certain disease components in your health, they can monitor your progress. They can make sure that you get to the doctor when you need to see the doctor. They can make sure you get the medications you need when you need them.
Don't they do that now? My doctor does that now. He makes sure I get all the right things.
Then he's more advanced. Does he only see you, though, when you're sick?
No.
Or when you come once a year?
Yeah, he'll see me when I set up the appointment.
Correct.
All right, so you're saying the doctors will tell people you gotta come in?
This will be a reach out. That's correct. I'll give you a very, very simple,
There
concrete
will be
example.
people that will say, oh, I don't want doctors meddling, telling me when I gotta go to the doctors or not. I'll decide that myself.
That is
Right.
very possible they will, but here's why we believe they won't. And I make this up, and to all the clinical people in the audience, I always apologize because I am not a clinician. If you have congestive heart failure, one of the ways that clinicians can monitor whether or not you need to see a doctor is by changes in weight. If you have a steady change in weight, you might be retaining water, which may be a sign that your heart isn't working as efficiently as possible. In some of the models we've looked at, the care coordinators and the hospital will actually put a scale in your house. And every day, you will weigh yourself. And they will get the results electronically, wirelessly, and they will see. If they see some unusual changes, they will reach out to you and say, we noticed something going on with your weight. We'd like you to come to the doctor's office for a visit. It does two things. Number one, it hopefully intervenes before you get seriously ill, and we can make you better, faster. And number two, it keeps you out of a hospital. So we're rendering good care, timely, efficiently, and cost-effective.
All right, but I don't have to, if he calls me up and tells me I gotta come to the doctor's because my weight is, I don't have to go, right?
We are not taking away your free will. But wouldn't you?
You know, I mean, there's no penalty.
There's-
Right, if I don't
Well,
go.
you're
Yeah.
But
Insurance company?
think, imagine a world where you'll actually feel better and the quality of life will improve. That you won't have to come into the hospital 4 times for pneumonia because you got the right care on this, what we call this medical perimeter. That there will be a host of caregivers wanting to, and the reason they're gonna want to help you is because now they will be incented and paid, rather than fee for service, rather than only getting paid every time you come into their office, or every time they see you in a hospital or do a test on you. They will be able to share in the savings generated from keeping you healthy. That's their incentive.
You talk about caregivers, you mean doctors, or are these gonna be newly hired people to participate in this?
Both.
Does that mean if you got fewer bricks and mortar, well, does that mean fewer people needed to staff those buildings? Fewer nurses, fewer janitors, fewer technicians? I don't see how employment is gonna be added.
Okay. So here's what happens over time. The hospital volume will continue to shrink because and you can see it right now, by the way, with Medicare. Medicare will penalize the hospital. If Paul happens to have pneumonia, and you don't mind if I use you as an example,
No?
has pneumonia and he's readmitted after being discharged within 30 days, the hospital's penalized for him coming back. So we need to keep him healthy and out of the hospital so we don't receive a penalty. Because the expectation of the federal government is, we need to take care of you and keep you healthy.
So the
So-
idea is to get involved in the care before people go in the hospital, so you
Correct.
guys save money, because you've been losing money for 10 years now.
So how does that relate to?
So, let me finish answering your question. So over time, the number of admissions in the hospital will shrink. There's no question about that. And that's a sign of us doing a good job. But what'll happen is that medical perimeter will start to grow, because we'll need to expand the number of people in physician offices. We'll be able to expand care coordinators who will be calling you. We will probably be expanding pharmacists. We will be working with nursing homes who will grow. We will be talking to ambulance companies who may come and visit you if need be. That medical perimeter starts to grow out. Maybe we get a little bit smaller. The net sum, as Mayor Gallo said, could be growth or it could be just the same. It'll be rendered differently. Always remember, the hospital is the most expensive place to render care. We want to make sure that the care is rendered in the best place at the lowest cost,
It could
without
be my-
compromising quality.
It could be in my own house. The doctor could come to my house and take care of me.
It very
make
well
house
could be.
calls
That's correct.
under this new.
Assume the outcome of the doctor coming to your house is equivalent to you coming into the hospital for 5 days, which is more cost effective.
So he's gonna sit in the waiting room for 3 hours?
He's gonna wait for me for 3 hours.
You gotta let him in, Kirby.
I think I'll pass on that question next.
You gotta let him in.
Ralph, I'm sorry.
Yeah, 2 questions. One, what is the time frame for the affiliation contract?
We are right now talking to 6 different affiliates, and those talks are at different levels of advancement.
Mid-year 2014 or end of year? Which?
I can't predict right now, honestly. I don't know.
And second question, could the affiliate, say, keep both campuses open? You said you're gonna decide bricks and mortar later, they may decide that.
That could certainly be an outcome, but based on the volume that we have right now, we're running at about 60% occupancy. It doesn't make financial sense.
We may need the space for perimeter expansion.
That's correct. That is absolutely correct. We could repurpose, as the mayor continues to say, how do we repurpose one of the campuses in keeping with the delivery of healthcare? And that could have a lot of different answers, depending who the partners are.
Is there any consideration?
Hang on,
oh,
just have a
sorry.
question. Yes.
So in other words, all of the information you will have access, as soon as you act on something, put on 2 pounds, that's all gonna go into the doctor's, group or wherever that information is stored. We now have, one, the proof that the transferal can be hacked into any time. And who's gonna make the decisions as to what is a healthy or unhealthy person? You may have a gene composition, a family history, a whole series of events. Who's gonna make the determination? Now's the time to call them in, based on this statistical analysis or based on this plan that comes down from some bureaucratic group? How are you gonna individualize it and keep it individualized, one, and second, keep it safe?
Right, number one, we've been working with partners who have been doing this for 20 years. And they've been doing it very successfully. Number two, the people who will be working with in the physician offices will know you. They'll know your history, they'll know what's wrong with you, what plan of treatment you're under right now, and any deviation from that will be the trigger for them to say, why don't you come in? This is not an impersonal interaction, this is a very personal
So
transaction.
if you go and you're having like a big dinner at the Thanksgiving or Christmas,
No.
and suddenly you've put on 5 or 6 pounds, you're gonna have how many people calling? The doctors are gonna be able to call all those people in
No,
for
with it,
referral?
no, with this, no, right, exactly, Josh is correct, this is not Big Brother. If I were to stratify the universe of folks in this, let's take folks in this audience, somebody described it for us a couple of days ago. Probably 90% or 85% are the well and worried, and if we're concerned, we go on to healthnet.com or we go to some other Google site to see what that pain in my shoulder or back is. Then we've got folks who are starting to become chronically ill, but then we've got the severely ill. It's about 3 to 5%. It's the 3 to 5% that we're going to be looking at because they consume probably 70, 80% of resources. So it's really the very chronically ill. If you eat too much on Thanksgiving, we won't know, and
Nobody's gonna call them up.
no one's going to hold it. And
So,
Some of the
when do you think that this is gonna all be done? Like, is there a time frame where this is all gonna be done? And, you know,
the done is the hard part because I mentioned before, it's a journey and it takes a lot of different partners and it depends how fast each of these relationships develop. Look, you take affiliation, we could start talking to an affiliate partner, and we have talked to some for 4 or 5 months. By the time you get the 2 boards together, let me just that's a great question. Let me walk through a kind of approval process. First, there has to be economic sense to do this and delivery of service. Number 2, you've got to get the boards on board. The boards think this is a good idea. We need Department of Health approval. We need Federal Trade Commission approval. There's a whole host of things that we just can't go and announce that.
this could be years.
It's potentially, it could take years. That's absolutely correct. But there's nothing we can't change that process.
Will it take years to decide which campus you're going? You said you still wanna go to a single campus. When will that be quicker? A decision made on that? So that's been put off indefinitely.
It's not, I wouldn't say indefinitely, we're not ready to make that decision yet. When the right fact pattern is in front of us, we'll make the right decision.
Has there been any consideration to rent space to these independent doctors, or make a cooperative space for doctors at the Kingston Hospital?
We always talk to doctors about that, and some doctors do rent from us. That's certainly a possibility.
Is there discussion of a medical college? Cahill mentioned that in his press release, and there were people that took over Golden Hill, said they had been interested in Kingston Hospital as a college location, I believe.
You
Yeah,
wanna-
actually, I'm the one who did propose it, I don't know the assemblyman, but I reiterated that particular subject with David earlier today, Paul. And Dr. Baki, okay, you're talking about from Golden Hill. Baki had proposed exactly what the state is requiring the Health Alliance to do right now, which which is to establish an integrated IPA, physicians network, juxtaposed with an affiliate. Now, out of that could very well come from that affiliate relationship, okay, a medical college. But I think it's premature right now because, as David was very specific, unequivocal, he's in the process of discussing, saying with 6 affiliates. And then once you do get an affiliate perhaps interested in becoming an affiliate, if they can jump on the bandwagon with the economic incentives, then the boards have to meet respectively, and then the agreement has to be crafted. So suffice to say, it is, in all fairness, very difficult to put a time frame on it, but the answer to your question is I'm optimistic that that subject is still on the table, which I had indicated at a press conference back in June with my BEAT initiative that was proposed to revitalize Midtown. Is that a fair assessment,
That's
David,
fair.
Josh?
Yes.
So, but while it stays open for years, right, you continue to lose money every year. I mean, that's, you know, I mean, you've been bleeding for 10 years now.
Our job and my job is to figure out how to bridge the gap from where we are today to our vision of the future. And we're gonna work with our local representatives to figure out what that answer is. That's not an easy answer, Paul. I wish I could give you a pat answer of, hey, I've got, it's not. We've gotta work through this.
So you could go back to the state again?
We could. We absolutely could. The state, here's what's really important about this. The state believes very strongly, and you heard both the mayor and the county executive say this, from the governor to the commissioner to the folks at DOH, they believe this is the right direction for us to go. They are encouraging us. My feeling is, as long as we continue to do the right thing and we're acting in the best interest of the community and the state at large, that we'll continue to get support when we ask for it.
They believed that you were doing the right thing when they announced that we were gonna close Kingston Hospital and just, you know, make one campus, and that was it. Didn't they believe that too? I mean, they sort of signed off on that plan as well, didn't they?
They didn't sign off on
They
that
did not.
plan.
Okay.
They did not. They signed off on this plan, which tells you that this is what they support. Again, this is not, you know, it's changing the paradigm, as we said before,
Yeah.
from volume to value. It's a fundamental shift. This isn't about us being bigger. This isn't about how we house, it's how we deliver. It's a little less quantifiable in terms of what you see, but you'll get better. It's about quality. Yes?
As a numbers person, where did the 6.5 come from? Because that is, as you pointed out, is a drop in the bucket. And as I listen to you expound on what you're planning and all of the network that you're going to have out in the rural communities and all the equipment and so on and so forth, forget it with $6.5 million. You can spend that in an hour, and you know it as well as I do. So what is what part is the 6.5? How did you come up with that as the starting point?
Yeah, we've been working, in the past, we had worked with some consulting groups who are very well versed in.
HPE?
No, that's a building issue. And we worked with them, and the estimate for doing, we actually came up with hard numbers of how much it would take before, see, here's the point. A lot of this is startup money, and once we get this up and going, it's self-sustaining. So all we need is a boost to get going.
This isn't much startup money.
We're thankful
Even
for,
in
we're
Kingston,
thankful.
Even in the rural area up here. this
We are
is not
thankful
much.
for whatever the state can give us. The state doesn't have endless deep pockets. And they've been very clear to us, they don't have a lot of money to be giving out. So we're very thankful for what we get.
I'm very supportive toward your efforts, as I think you know.
Yes.
However, I will try to eat less at Thanksgiving anyway, just because impressed by all this. I think that the lady had a good point, that it's how to get, in practical terms, how to get from here to the next step and how much money you need. And indeed, if I were offered $6.5 million, I'd probably find a way not to refuse it. However, I think we need to get into specifics a little bit. Could you tell me how much Health Alliance lost last year? And secondly, could you give me a head count of employment now compared to what it was, say, a year ago?
I can give you the, off the top of my head, I can give you the loss for 2013 through October. It's a little less than $3 million.
Okay.
In terms of the head count from year to year, I don't know that off the top of my head. I'd be guessing. It is lower. That I can tell you. I don't know the number.
Okay, thank you.
Are there penalties attached to this plan, the money? In other words, are there checkpoints where they say, well, you didn't meet this, so, you know, we want money back, or, you know, you're fired, or whatever?
The last one, I'm not sure. But, the others, here's the way it's a HEAL grant, and the way HEAL grants work is you, the hospital, need to spend the money, and then you voucher for reimbursement from the state. So when you voucher, you need to prove to them that you use the money for the appropriate purpose, and it's consistent with the plan that we laid out for them. So they do monitor that very, very carefully. And if they feel that you've spent it incorrectly, they will not reimburse you for it. So there are checks and balances. We also said to the Department of Health that we would love to be a demonstration project for the way healthcare should be delivered. We are totally transparent with them, and we invite them to give us suggestions about how we should do this. But we want to be the poster child for how healthcare should evolve.
Have you seen this model at other, hospitals?
Yes, it works across the country. If you pick up any healthcare magazine, you will see a couple of the items I talked about. Population health is everywhere. We're not inventing it. We'd love to perfect it and steal shamelessly for those who came before us, but population health is used very, very widely.
So the doctors employed in the group, right? The Alliance, they would be the ones participating in this population treatment program?
They're not gonna be employed, but yes, the physicians in this physician alignment group, yes, they will be participating.
So what if my doctor's not in it?
That he can choose or she can choose not to be in it. They will not, here's what they won't be able to benefit from. As the cost of healthcare shrinks, they don't get to participate in the sharing of that savings. This is, we're gonna change payment mechanisms. Instead of getting paid solely on fee-for-service, you're gonna get paid based on shared savings. And shared savings means, and we'll use Health Alliance as an example, it costs us right now on an annual basis $15 million to insure the population, the employees, and the dependents of Health Alliance annually. If we work collaboratively with a group of physicians and a payer and an employer, by the way, Health Alliance, and we're able through this care coordination and population health management reduce that cost from 15 to call it 14. There's $1 million of savings that the insurance company will distribute to the participating providers. It doesn't mean rationing.
The insurance company is given incentive to do this.
Correct. It's based on value, quality, outcomes. It has nothing to do with rationing. It has nothing to do with Big Brother. It has everything to do with you've improved quality of life of people. These are measurable quality indicators. If you get it down to 10, you share in $5 million. To give you an example, we have had some conversations with Montefiore Hospital and Montefiore Medical Organization. Montefiore Medical Organization has participated in this last year with Medicare. It's called a Medicare Pioneer ACO. They saved $25 million by doing this successfully.
The population thing.
Correct. And we are having discussions with them to see if they would be a good partner for us.
The other piece, if I can just add to this, is that as if each of you obtain insurance, whether it's through your employer or whether it's through the New York State Health Insurance Exchange, or however you decide that you can purchase insurance, the reality is, as you've probably seen, the cost of that insurance is quickly being shifted to the individual. So the individual is now much more incentivized based on your out-of-pocket expense to take more accountability, or at least to monitor their overall health status. And so now we're trying to work with our physicians and eventually the employers to say, as you begin to look at the quality that's delivered for your out-of-pocket expense, how do we raise the bar by using evidence-based medicine, by using best practices to make sure that we're delivering that value to everybody that uses our facility. And that's an important aspect, because you may not realize it today, but healthcare is quickly becoming a consumer-based market. As individuals go to buy their own insurance and they're much more accountable for the co-pays and deductibles, those dollars become an incentive to the individual to make sure that they're buying the highest quality, lowest cost healthcare that they can.
Under this plan now, you said the doctors will no longer be employed by the Health Alliance hospitals. What about the nurses, the specialists, the other staff and all? They will also have to go as, in a sense, independent contractors with an alignment?
Well, let me just clarify. It's not that the physicians will no longer be employed. They're not currently employed. What we're looking to do is partner with independent private practice physicians in a more financially integrated way, number one. Number two, to answer your second question, yes, we will continue to have technical staff and nurses and others that work with us within the facility. We're also going to see that population of employees grow, as Dave mentioned. Physicians, while they're not technically a shortage here in Ulster County, we're very blessed that way. Across the country, there's a physician shortage. So you're beginning to see a lot more healthcare delivered by nurse practitioners and physician's assistants. And that's just another example where we're going to begin to see movement in how healthcare is delivered.
You did not say that those nurses and technicians would continue to be employed by the hospital, will they?
Well, we will certainly have nurses and technicians employed by us. The question that I think you're referring to is will we be continuing to employ them at the same level? And the answer is we don't know, but likely no.
Well, what about competition? There's a big, last I looked, yellow building out by the mall. That's I think a doctor's group that's coming in your backyard. You know, are those people going to be eating your lunch?
Two things. One is many of the physicians that are going to be moving into that building, and that is Mid-Hudson Medical Group, it may end up becoming part of another group. Many of those physicians are currently in our community. So they're going to be relocating under one roof. Yes, there'll be some additional physicians there. The second piece of that is, yes, we are seeing an outmigration of our outpatient ancillary testing to physicians' offices, not only by that group, but by all physicians out of their own necessity. These physicians have to continue to pay their staff and grow their revenue base. And so they're looking for opportunities to do that, and that's why that's occurring. What we're trying to do is say, how can we work together? Because right now, if you go to your physician and you have an x-ray done in their office, they know what happens within the four walls of their practice. We know what happens within the four walls of our hospital, but we're not yet connected in terms of the information systems. So part of what we're talking about in terms of clinical integration is how do we begin to share information in a meaningful way that isn't Big Brother, but begins to improve the total outcome of the health of this community.
It sounds from what you're saying today is that our two hospitals are being downgraded to a big HMO. Would that be an accurate characterization?
No, absolutely not. Absolutely not. What we're saying is, right now, the current way hospitals are reimbursed and have been reimbursed for a long time is based on volume. It's based on how many patients you can treat in a day, how many procedures you can do, and that's quickly changing to a value-based system of reimbursement, meaning it's not only about the procedures you do, but it's also about how healthy you can keep individuals. HMOs, I don't want to get into the debate of the value of an HMO, but I think what we're saying today is we will continue to look at volume, but the more important aspect of hospital reimbursement is going to be outcomes-based.
Do you think our two hospitals would have been better off if the Burger Commission never came in and meddled with it in the first place?
That's total speculation. I have no way of me being able to answer that question intelligently and be able to look back and not Monday morning quarterback on that. But what I can tell you is that when you look back at the original goals of the Burger Commission, which was to preserve jobs, which was to preserve the individual missions, we were able to do that at that time. So I don't think it does anybody any good to go back there and look at what could have been or what was done. In the last 5 years, healthcare has changed dramatically, and in the next 5 years, healthcare will continue to change.
So you're saying that the hospitals, nursing staff, technicians, maintenance, et cetera, that they no longer will be part of the hospital's health alliance. Does that mean that they will all have to transition under new terms of contract and everything, with Health Alliance provide the services in this new formulation of what healthcare will be.
That's not what we're saying. What we're saying is we will, as a hospital, always have nurses and technicians that work for us. What we're saying is there's going to be more of those individuals that also now work for laboratories, private practice physicians, individual physical therapy centers. There's going to be some broad job growth in those areas. So that's what we're talking about in terms of the overall employment level for healthcare in Ulster County. If you look across the Hudson Valley, one of the major growth sectors has always been healthcare.
One of the requirements of the Burger Commission was the delivery of abortion services to people on product. Is that happening?
Yeah, I think, let me just be clear, and I don't want to spend too much time on this today. We have the ability to do those procedures at any of our facilities. We don't actually currently do many, if any of those, because of the lack of a physician to do those procedures, number one. And number two, as we said in the past, it's becoming less and less important because of the medical intervention for those procedures. But I don't want to spend any time additional on that type of question.
Yeah, I do want to spend a minute, because the question over here was, what will happen over time as we lose some volume? And you have to remember that over time, we have lost volume because the delivery of medical care changes. Years ago, if you had an endoscopy, you came to the hospital to do it. Today, you can go to a physician's office. Years ago, if you needed surgery, you spent 2 weeks in a hospital. Today, you can have it done in an ambulatory surgery center. Physicians in their offices didn't have imaging equipment. Today, you see the big yellow building, there will be imaging. It changes. Our life has always changed. Medicare people who come in with pneumonia will not come in within 30 days. Who's going to help keep those folks out? The nursing homes will. We're working collaboratively with nursing homes that say to us, if you give us folks being discharged with pneumonia, we will guarantee that they will not come back in 30 days because we will take care of them. Our world has always changed. It will continue to change. We will look different. That's not a sign of failure. It's a sign of progressing. Yes.
I have an answer for you on the abortion question. This is directly from the New York State Department of Health. It said the New York State Department of Health does not require the hospital or ambulatory surgery center to perform abortion procedures. However, it is properly licensed to perform such procedures. When Kingston Hospital and Benedictine Hospital merged, Kingston Hospital was obliged, pursuant to the Catholicity Agreement with the Benedictine, to cease abortion procedures at Kingston Hospital.